Welcome, everyone. On behalf of Flagler Cares and One Voice for Volusia, welcome to the 2021 Health and Human Services Summit. I hope everybody had a good morning in session. Anybody go to the keynote speak at lunch? Very, very good speaker. Really enjoyed her. My name is Deanna O'Flaherty, and I'll be the moderator for this session. You've joined the session titled Rewire and Recover. All participants will be muted during the session. There'll be a Q&A time at the end of the session where you can pose questions. You may raise your hand using the reaction button that's down at the bottom of your screen. We will then call on you and allow you to unmute yourself. You may also submit questions during the training in the chat box, and I'm happy to help answer those or get those to the right people for you as time allows. Thank you to our sponsors who made this event possible: Advent Health, Career Source Flagler Volusia, SMA Healthcare, Magellan Complete Care, Department of Children and Families, and the house next door. It is my pleasure to introduce your trainer for this session, Dr. John Symeonides. Take it away, Dr. John.
Well, thank you much. Thank you, Deanna. Good afternoon. Hopefully you had a nice lunch and everybody enjoyed the keynote speaker. Today I'm talking about MAT. MAT is medication assisted treatment, and basically it's mostly geared toward opiate use, but of course medications has been used for addiction for years and in different ways. Why MAT is important? MAT is critical and a big component of treatment of addiction. It's clinically proven and studied and evaluated methods that try to determine what helps in overcoming addiction. As previous speakers spoke, right? Addiction is a horrible disease. I mean, it's bad. It's a chronic. It's terminal condition that really, there's very difficult to obtain cure. And literally, we think about it more like a cancer or an infection or parasite that gets inside your system and kind of helps to control, controls your vital organs in the brain. What causes addiction? Of course, as previously the speaker said, there's different reasons for the addiction, but nevertheless, it is an interaction inside the body about an agent, host, and environment that they come together to create the disease. What is the approach for it? There's no question. For years, we did not have any medications that they were effective. So the psychosocial treatment, the behavior treatment, the counseling, support groups, 12-step program were the mainstay, if it's not the only, to try to help in addressing the disease. And then we start understanding more about the brain, about how it works and functions. We start understanding more about medications. What do they do? We start thinking about drugs as medications in a way that they really go in the brain and they do something different. We found out most of the drugs work in mainly two mechanisms. And one, they work in the neurotransmitters or neurotransmitter modulation, or they can mimic the neurotransmitters. And by this action of them, they affect the way we think, the way we act, our behavior. The most effective treatments were in the reward system. The reward system is where dopamine is released. And as we know, the most important and most potent products that they affect that reward system are the opiate systems. The opiates, and those can be different things, starting from Of course, heroin, opium, uh, kratom, all the way to heroin and fentanyl and synthetic fentanyls. All they work in the same way. They work on the reward system by stimulating it and then releasing the dopamine. Um, so we know it's really structural damage to the brain that happens from the drugs. We do know functional MRIs do show clearly that the brain changes. We have parts of the brain, they shrink and they get damaged. And that's this is unquestionable. So it becomes, even though in the beginning it can be a behavior, but very soon, that especially when the disease advances, becomes organic. And we have to look at it as an organic disease. We have to look at it as it's a condition that requires intervention. Because when we have a defective brain, it's just like having a defective vehicle, it's not able to perform right. No matter how you can get the best fuel you want in that car, but if it's defective, it's not going to perform right. And so medications, they try to help. And there's two groups of medications, of course. The medications that they address, basically, as we said, the receptors or the neurotransmitters like, and the medications that they help in alleviating symptoms. And we use them in combination. Just like any other mental or physical disease, we try to use the best combination for the individual person. And sometimes it is a trial and error. And that's why ASAM, the American Society of Addiction Medicine, very clearly recommend it should be a co-work together between the provider, physician, and the patient to try to figure out what the best combination is, what modality to be used. Everybody has to be on the same page. It should be a team approach. With MAT, we tried regarding opiates, we use mainly three medications we have there. The one is the methadone, and that's the first one came out. And it's an opiate agonist. So that means that it works just like any other opiate. It is an opiate. It goes on those opiate receptors and fills them, saturates them. And as that happens, then the person has less need to be preoccupied, thinking and craving and looking for an opiate because the opiate is already in his system. They are proven and they are good, effective medications because they make you function better. The thing, of course, that traditionally they have to be dosed once daily, and usually they have to be supervised. So that means the individual has to go to the facility to be observed and make sure that he takes it or she takes it properly. The second group of medications are the buprenorphines. Buprenorphine is similar to the methadone, but it's different also because we call it partial agonist. It's not a full agonist. Partial agonist means it does have part that looks like an opiate, but also has other part that it's not an opiate. So what happens, it goes to that receptor and sticks to it. So the receptor feels saturated, feel satisfied, feel comfortable. At the same time, it does block other opiates from coming and working on that receptor. So in a way, it's considered a little bit safer because of the blocking effect of other opiates. That's something you don't have with the methadone. But it's a partial opiate. So if you stop using it, you're going to feel withdrawal, you're going to get sick. And the withdrawal is one of the major causes for people to relapse and go back and use. The third group of medications are the opiate receptor blockers. And that will be the naltrexone, naloxone. Those, of course, the naloxone, we know it as antidote for overdose, and that's what it's used for. It does reverse the disease. It's the overdose. The naltrexone per se, and in therapeutic an appropriate use, what happens is goes to those receptors and sits at them. As long as those receptors are not, there's no dependence, means they're not, they are available to function, sits on those receptors and blocks the opiates from coming to him, but also at the same time blocks the cravings, the thoughts, and the urges, and the need to use. So by doing that, can quiet the brain and give the brain relaxation and comfort, so the brain is able to function normally without having to think or crave or seek the opiate use. The naltrexone, it does come in long-term preparations, once a month shot. So it's very effective in that way because you give it to the person once a month and they feel normal and they don't have any cravings, they don't have any thoughts. But you know, it's not for everybody because some people just, they don't do well with just a blockage. They want some stimulation, they want an opiate effect. And those individuals do better with using things like the methadone or buprenorphine. The trademark, of course, the trade-off is that the naltrexone is much safer. You can't overdose on naltrexone. With buprenorphine, it's less likely to overdose unless if you use other drugs with it, like benzodiazepines, and that's something we need to make sure that people are trained and they're educated about not using them. And of course, with methadone, you can overdose. There's no protection there.
Dr. Symeonides?
Yes.
One of the panelists asked, what is the success rate of treatment of opioid disorders with MAT versus without using MAT?
Okay, there's no question. I mean, there's several studies has been done, and there's a very good review by FSAM that they took 42 studies and they evaluated all of them. And there's two things. The success, it's about 40% more adding MAT to the traditional therapy. And you have also about maybe 35% more retention of abstinence on the MAT. But again, MAT is not for everybody. It's for people who are having struggle, who are having difficulty with handling the situation, which have weird things in the brain, which have, you know, and that's where really good evaluation also is the beginning of treatment. Because you're giving, MAT by definition is you are trying to treat or cover up symptoms that they are there. It's not, I mean, if you're hot, if you're depressed, you're going to use an antidepressant to use them. Yes, treatment therapy can help with depression, but it's much more effective if you combine it with another, with prescription like SSRI, for example. Same thing with hypertension. Yes, hypertension you can address with therapy and treatment by itself, you know, by lifestyle modification and all that. It does help with improving the blood pressure to a degree, but a lot of people, they need prescription medications, again, to try to control the symptoms, to try to control the pressure. And really, we have to, more and more, we're thinking about addiction just like an organic brain disease, just like anything else that we have that need to be addressed in such way. So there's the answer again, it's about 40% for short term and about 35% for retention, more and above the just using the traditional treatment.
Thank you. Another person has asked, when do you recommend prescribing Vivitrol versus Suboxone?
Well, good. So methadone and Suboxone are used for people who have physical dependency as well. So that's the key. If they have physical dependency on the drugs, if they feel sick and withdrawal, then we cannot use naltrexone. Not at least in the traditional way. And we have to use the buprenorphine and methadone. If they don't have physical dependence, but only psychological dependency, and that's usually achieved after detox or weaning, or people who have, they use sporadically off and on. And that's, again, something that the provider has to evaluate before they start any kind of treatment. And so that will be a better candidate for just blocking the receptors. They will stop the cravings, they will stop the will, they will stop having the desire and the need and the thoughts of using, so they can function normally. So going back to the that Hippocratic tradition is like doing the, having the least effect that is effective, doing the least that's more effective. You have your focus on, if you can just block that receptor, it's better than blocking the receptor and saturating at the same time. It's better than just not blocking it and just saturating it with another opiate. That would go with that, but some people just, they don't do well, and especially when that part of the damage in the brain happens, is people becomes the TA becomes shrink, and the people start feeling depressed, unmotivated, tired, weak, and those sometimes can be indications to try to get something more has an opiate activity to give them that little bit more energy. It's really something fine-tuned and switch back and forth. Sometimes you don't just stick with one and then that's it, that's what you have, because things do change. Okay, yeah. Is there any other questions?
If you have a question, you can put it in the chat box, or you can use reactions down below and just raise your hand, and I will unmute you so that you can ask your question.
Okay. So, and it's a lifestyle. I think it's, so I do deal with professionals, like I tell you, for example, like, I deal with pilots and physicians and providers. Most of the licensing, institutions, they would not accept an opiate substitution. Okay, and that's something important to know, because they feel it can impair the individual and it can increase the risk. So they recommend substances like Vivitrol. So if patient is a healthcare provider, physician, nurse, or a pilot, then they will have to take something more like Vivitrol.
We had another question in the chat box. As a family member of a person with co-occurring conditions, what are the risks of psychiatric meds and these types of meds?
All right, good. Well, there's affiliation and there's association between addiction and psychosis and psychiatric conditions. There's no question about it. A lot of the same circuitry that affects the person with addiction, they're affected in psychiatric disorder. We know a lot close association, for example, between bipolar and addiction. There's the contemplation is the same circuit in the brain is affected, and the same, a lot of the same deficits. And it comes about regulation, about balance. Inside the brain, there's circuitry that really gets messed up for whatever reason. It can be hereditary, or it can be genetic, and that can be a effect. Also, we know some medications, especially like marijuana, that can cause itself psychosis, or it can cause bipolar disorder. So, if people with bipolar or psychosis have higher tendency to use drugs to self-medicate, but also it's vice versa. Drugs can cause psychiatric disease, which is permanent. It's irreversible. Despite stopping the drugs, the psychiatric disease can continue after. The medications we use, sometimes we use antipsychotics, and the reason of that is if they have psychotic symptoms. Again, that's part of trying to control symptoms. I talked a little bit, I discussed that briefly a little bit earlier about how to control them. It's basically somebody nauseous, we give them something for nausea, somebody stressed out, we give them something for the stress. If someone can have trouble sleeping, we give them something to help them sleep. And that's, again, it's symptom control. Same thing with the psychosis, same thing with depression. We try to control those symptoms by giving them medication to try to help with them. And then again, it's important to try to figure out the best combination of medications we can use to alleviate a lot of those symptoms. But yes, the antipsychotic use, antipsychotic itself, they have effects in the brain, and they do make changes in the brain as well. And hopefully those changes are desirable and they're therapeutic. But if the person uses drugs, then they might need antipsychotics to try to control the damage that was done by the drugs themselves.
Thank you for that answer. And we had one more question. What is the percentage of addicts who are prescribed methadone who trade one addiction for the other, so to speak, and how do those things turn out for those clients?
Okay, so by definition, addiction is chronic relapsing disease that accompanied by cravings and desire to go and use to get satisfaction. For individuals being treated on methadone, if they are being treated properly and monitored properly, I will argue that is no longer addiction. Saying that, of course, it's higher chances for people to abuse or misbehave while taking methadone, even though being tested on a regular basis and everything else. But the thing is, because methadone does not stop you, it does not stop you from going and using, because it doesn't have any blocking effect, unlike buprenorphine or the naltrexone, which have blocking effects, so it makes it less likely to benefit from using. A person on methadone, if they want to get high, they can just go and use drugs and they will get high. So that's why it's less, but it does help with stabilization. It does help with reducing cravings. It does help with stopping with the withdrawal or preventing withdrawals. And the fact that it's being monitored daily basis, it does have an advantage over the other drugs because people are being seen and evaluated on a daily basis.
Excellent. Thank you so much. We have another question. There are many more waivered providers in the community than those who will actually work with patients with SUD and prescribe MAT. What do you think we can do to expand access to MAT throughout Volusia and Flagler County areas?
Well, we have to be careful with that, of course. Just prescribing MAT does not necessarily helps the patient. It's not a prescription. Of course, the waiver has been around for years and was one way to try partially educate some providers to be able to prescribe a medication. But they're really, that doesn't train you on treatment. And just having medications out there is like, just having over-the-counter, I don't know, Tylenol or ibuprofen, and then saying, well, you fixed the pain problem. Really, it's what you do underneath. It's how you're motivating the person, how you're challenging the person, how you're monitoring the person, how you are helping the patient with other symptoms, other signs, and how you are moving them through treatment. So the key, again, going is treatment, is therapy, is not the medication itself, because medication is not going to do anything. It's going to just stop you from wanting, stop you from needing, but doesn't get you to normal functioning.
Excellent. And you mentioned earlier about marijuana use, and so someone had the question, can you speak on that in relation to CBD and nicotine addiction?
Okay, so like, for example, going back to nicotine addiction, we do have something that has been used, a MAT therapy for that for years. And in addition to the alpha blockers that we use, of course, it's, we use Chantix. I'm sure everybody heard about Chantix. It's an MAT, believe it or not, and that was initially was introduced as an MAT for the nicotine addiction. It does work on the receptors, blocks that receptors from being stimulated by the nicotine and decrease the pleasure obtained by the nicotine itself. Naltrexone we use for the nicotine addiction as well, because it does help with blocking the satisfaction and, most important, the withdrawal from the nicotine itself. So yes, going back to marijuana, unfortunately, we don't have good medications there to stop marijuana. We use antipsychotics because we know it works on the psychotic part of the brain. But again, it's not, it's not completely studied. There's no like good cure for marijuana yet, but definitely it does have effects in the treatment, because it can mix the interaction with other medications and treatment. And I know a lot of people, they use it. They feel like it does help them, make them feel better, make them feel more normal. But the bottom line is, it is what changes are making and how much of that becomes dependency on the marijuana itself. Because it is addictive and there's dependency. 10% of the population becomes dependent on it after use, and they have tendency to use it more and more. And if they don't use it, they start becoming irritable with withdrawal symptoms. So I discourage people who have any kind of addiction to be using marijuana. I discourage them from smoking nicotine as well. Again, because you're still, that's when, what you said, you are trading addiction for addiction. We know people, individuals that they will smoke just because you say, oh, at least it calms me down. And by the bottom line, it's so hard for them to stop it. So difficult to say no, that I'm not going to smoke and I'm not going to use any. Despite trying, it many times can be very challenging and difficult to stop that habit. Same thing with marijuana.
Do we have any other questions?
So one last thing about marijuana, just you need to be careful, because if you ask people who abuse marijuana, they use it just to buy time. And, they tell you, my drug of choice is opiate, but, I will use anything I can if I don't have the opiate. I use an alcohol, I use marijuana, I use whatever. And a lot of people, they will use marijuana to try, just it gives them a little bit of satisfaction, because it does increase, release dopamine in the brain. It works in the pleasure center. But the thing is, once they get the drug of choice, they will go back to it.
Thank you. That was excellent. Do we have other questions or other information you wanted to share today? I had a question actually. Where can providers go to get more information about MAT for their clients to help them understand what it can do and how it can help them in their journey?
Excellent question. Well, there's different. Well, there's an organization called FSAM, Florida Society of Addiction Medicine. That just happened for me to be the president. But it's an excellent organization. It has been established in the state of Florida for the last 25 years. And so it does have good resources. We have our annual conference, but also there's very, very good resources that you can just obtain from that website itself. Also, in addition to that, there's a Flagler Or. I'm sure you heard about it. It's a great place and a great addition to our community. And definitely, they have good information about MET. I wish there's more. And problem, when you go to the internet is, it's confusing, and so many times it can be misguiding. But really, it's I hope it can have hospitals, the primary care providers, if they talk to their primary care providers, I'm sure they can help with the having access to MAT, and definitely I really urge the every person in therapy, every provider to look into medications assistance. I know, the traditional says that you have to do it on your own, but also the tradition say you cannot do it on your own. You have to give up, and you have to look up for the higher powers. And I'm not saying that, that's not good enough, but I think it does make sense to make things easier on the person, to try to provide them with comfort and medication that they can assist with their disease. Makes it easier for them to live and be successful.
Thank you very much. That was excellent. Did we have any other questions or anything that you wanted to add today to our group? You guys have asked great questions in the chat box. Thank you so much. It's getting late in the day, but everybody is really engaged and making the most out of these sessions. So thank you all for that.
And please, everybody can feel free to reach out to me. My office is open and available for anybody who has any kind of questions about MAT. I'd be more than happy to talk in person to anybody and reach out to them.
Well, that is an amazing resource right there. If you didn't get anything else out of the Health and Human Services Summit today, then you got that connection. So thank you all. Well, everybody, there is other sessions coming up after this one. I'm going to put the link in the chat box so you can get back to the main meeting area and choose another afternoon session. And thank you, Dr. Symeonides, for joining us today. And if everybody, if you have any questions afterwards, please don't hesitate to reach out to the organizers for the program. Thank you so much.
Okay, well, it was my pleasure, and thank you again.
Thank you, everyone.
Bye-bye.
Thank you.